the factory worker. Millions of migrant workers, the people who not just build our homes but our entire lives, left without work, cash, and food. More so, left without the dignity of anyone knowing where they were and how they were, till they started walking. The visuals left us asking, why didn't we know better? We should have. But the truth is, even today, we know little about migration within our own borders. In a country where close to 30% people migrate, shifting villages, cities, and states to earn a living, not having an understanding of who goes where, when, and why impedes our ability to plan for the welfare of around 400 million migrant Indians. Omidyar Network India presents the Indian Express THINC, Decoding India's Internal Migration, a series of solution-oriented conversations with thought leaders to discuss key issues that enable us to know better and plan better, and most importantly, help us improve the economic and social conditions of our migrant workforce, the workforce that keeps us going.
Good evening, everyone. On behalf of the Indian Express Group, I welcome you all to the Indian Express THINC series on migration, presented by Omidyar Network India. IE THINC is a thought-provoking forum that brings together thought leaders, policymakers, and corporate leaders to encourage a substantive exchange of ideas and get the best minds to give it direction and solutions. We've hosted 2 editions in the migration series before. The first was Decoding India's Internal Migration, and the second was Migration, Are the Indian States Ready and Capable? Today, our topic is how COVID impacted the health of migrant workers. In this session, we will begin with a keynote address followed by a panel discussion. So please join me in welcoming our keynote speaker and distinguished panel members. First, our keynote speaker and panelist, Chairman of the Maharashtra Real Estate Regulatory Authority, Ajay Mehta. Then on the panel, we have Professor K. Srinath Reddy, who is President of the Public Health Foundation of India. We also have with us Uma Mahadevan, Principal Secretary, Panchayat Raj in the Government of Karnataka. We have Dr. Pavitra Mohan, Director, Health Services in Ajivika Bureau and co-founder, Basic Healthcare Services. And finally, Dr. Vandana Prasad, Founder Secretary, Public Health Resource Network. This session will be moderated by Udit Mishra, Deputy Associate Editor, The Indian Express. I would request all of you to remain connected throughout the session on social media, as well as by using the hashtag Migration in India. Before we proceed further, we have a short video clip on India's migration from Omidyar Network India. So let's have a look at that. Thank you. May I now request Udit Mishra to please share the introductory note with us.
Thanks a lot, Pooja. Hello and welcome to everybody and the 3rd edition of the IE THINC Migration series. And as Pooja has also already mentioned, we've already had 2 rounds at this issue of internal migration in India. And we've found some remarkable things that around 600 million can be construed as migrants in India, and that a lot of migrants are within each state, not always interstate. But the topic today we've chosen is to look at health. That's, I think, the most timely topic because the second COVID wave has just reminded us how woefully short our health infrastructure is in the country. But many of us, the viewers sitting in cities, and perhaps from the most well-privileged backgrounds, have just realized that even numbers of beds per thousand, doctors per thousand people are not anywhere near, they don't capture the reality of how inadequate our system is. And the fact of the matter is that as against last year, when a lot of focus was there on migrant workers, this year the focus seems to have shifted. Uh, the debate and discussion is all about cities and about people like you and me. But the truth is that if we found it difficult with our access to healthcare in terms of institutions where we could access it, in terms of money, in terms of privileges, we can just only imagine how much more difficult it would be for migrant workers. And when we talk about migrant workers, we're not talking about people like me or you perhaps, who are not working in their home town, but often away and often shifting. This is a migrating population which moves and has difficulties in just justifying who they are, identifying who they are, registering for their benefits. So the idea today is to look at how much more difficult it was for migrant workers to deal with the COVID scenario. But we will not stop at that. We would obviously look at the COVID impact on migrant workers, but also pull back and ask some larger questions about the inadequacies in the system. And again, I'm not talking about just the hospitals' beds, but in terms of policy framework, in terms of how easy it is for them to access information, for them to trust the systems, how easy it is for them to even assert their identity, or as soon as they cross the state, continue to access some of the provisions that are there in laws. And that is why we have a panel here which is really stellar. One glaring omission, it would appear, is the fact that there is no private sector, sort of big corporate private sector entity here. And there is a reason for that. We tried, but there is very little understanding in the private sector, especially in the big corporate private sector health provisioning, about migrant health. This is a topic almost totally dependent on what the government does and what some of the community physicians and community practitioners do. And so we have some of the best names here. I would sort of come back to detailed introductions later, but first of all, let us start with a keynote address. We have with us Mr. Ajoy Mehta, who's the chairman of Maharashtra RERA, the real estate regulator. But more importantly, till just about a couple of months back, Mr. Mehta was the principal advisor to the Maharashtra's chief minister. And Maharashtra is one state, if there's one state when we think about migrants and migrants going to one state, that is Maharashtra. And he's a retired IAS officer, he's seen a lot of migrant issues right through his career, and especially in the last 1 year. And now he's heading an industry which actually employs most of them. So it would be very interesting to hear how he saw the situation, what he thought could be done, and how could we possibly reimagine some of the issues that we are facing on migrant health. So let's hear from Mr. Mehta.
Udit, is the link clear?
You can speak, sir.
Yeah, thank you, Udit. And thank you, Pooja, for that excellent introduction to the subject and to sort of kick it off. In fact, Udit, when we look at migration generally tends to evoke very sort of negative feeling. It's an ugly word. The minute you say migration, the first thought that comes to you is, oh, there has been a disruption somewhere. So it's either an economic disruption, it could be a political disruption, it could be something as shocking as the pandemic, which is just the COVID crisis. So that's something that is negative in its connotation, the very connotation. But we must also realize that migration finally also has served some good in terms of, bringing together a large group, a critical mass, which then leads to some sort of an economic growth and economic engine. Urban centers are fundamentally results of migration. So while there has been good, but the word migration normally evokes very negative feelings. So when you have a negative feeling towards a word and towards migration, the first reaction of policymakers is, oh, well, we have a problem at hand. And therefore, if you have a problem at hand, I must find a solution. And that's the first reaction. Because if you have a problem, you just find a solution. We tend to forget that behind this problem, or in fact, the front face of this problem are people. We tend to forget the people and we look at the problem. And the minute you look at the problem, you're looking at a solution. And because you've forgotten people, compassion is gone. There's an absence of compassion. So if you looked at the people and tried to find compassion, I think we would have better ways of dealing and engaging with the situation rather than looking at the problem and engaging with the solution. What is the solution as policymakers? As chief secretary, when I was there and the big migrant crisis took place during COVID, the first reaction was, how do I get them back in an orderly fashion? So any bureaucrat or any policymaker, the first reaction is order, order, order. Let's get order into the situation. Is that the only thing? Are you looking at an orderly migration? Is that the end all of everything? If I have achieved orderly migration, if I have been able to see, is the link clear? I'm sorry about this. Udit, can you hear?
Yes, we can hear, sir. We can hear.
Yeah, is it clear?
Yeah.
Yeah. Now the picture tends to freeze. So I thought. So the minute I feel that I have got order into the whole chaos, or the trains are running on time and people are getting their seats on the train, they know which day the train is leaving, which village is it going, where will it stop, the food is there on the train, everything is in order, I think the problem is solved and that's where we are. But we tend to forget that behind this order, there's a lot of chaos in the minds of the people. There is chaos as far as their health and other status is concerned, and that's something that we need to deal with. Also, you must realize the kind of people that you're dealing with when you're dealing with migrants. A migrant fundamentally is at the bottom of the pyramid, whether it's his health status, whether it is his economic status, whether it is social status, and even his feeling of well-being or being wanted or being, as they say, psychologically feeling safe. Even there, he's at the bottom of the pyramid. By migrating, he has further aggravated his situation. In fact, from being at the bottom of the pyramid, he's now gone to a pyramid where he has dug deeper and got into a further bottom. He's finally gone and replaced somebody who was getting the lowest wages because he can now survive with a much lower wage. Somebody had a fear psychosis. This man has a much bigger fear psychosis, and therefore there he is. So you're dealing with a class of people who are really at the bottom of the pyramid. And that is why I again and again say that the basic tenet of the policy has to be compassion. Now, when you look at that, what are the kind of policy interventions that we are looking at when we look at health of migrants or when we looked at health during the COVID times? The first and foremost thing is that let us not look at it as an enforcement issue. Let us not look at it as a demographic danger that here is they come in and therefore my whole demographic equation is going to get disturbed, which will have political repercussions. First, let us look at it as a human problem that needs to be dealt with compassion. The minute you look at that, you will realize, the first thing that you realize is here is a person who's completely fearful of the system. So while in Maharashtra, I'll take example of Maharashtra because I've worked and served in the state, most of the urban centers where the migration take place, whether it is Mumbai, I was municipal commissioner Mumbai provides free healthcare in its corporation hospitals, which are very, very well stocked in terms of the human resource or equipment or anything else. But how many migrants know that the medical care here is free and that you don't have to pay anything? And even if they knew it is free, how many migrants would gather the strength to walk into a municipal hospital and demand a service? So the first thing is that you're dealing with a psychology, which is one of fear. He may be dressed differently. He speaks a different language. His mannerisms are different. And therefore, he finds that himself at odds with the whole system. He really can't gather strength to get into the system, that the government hospital and or a corporation hospital and get himself treated. Therefore, he tends to fall back on the private health system, which can be prohibitively expensive and also can at times I won't make that allegation against everybody in the private hospital healthcare system, but at times could also take him down a ride which is very expensive and sort of rip him for the cost which he really didn't want to, and should not have been paying for. Let us look at the larger policy issues that are coming up in health. When you look at the health structure in India, or for example, any city or anywhere in this country, most of the health is vertically driven. So we have a program to control malaria, we have a program to control TB, we have a population control program, we'll have something to control AIDS. So you have all these, we have a program to see that there's universal vaccination, preventable diseases, and how do you stop that? All that is in place. But in these verticals, do we have a common thread running that all these verticals are also required by a migrant who will have special needs and would have certain disabilities while he is approaching the system? First and foremost, as a policy, we must realize that while we operate in verticals, we must have an overarching policy which sort of punctures into each vertical and says, well, here is a subset which deals with the migrant trying to get a cure for malaria. Here is a subset which deals with a migrant trying to get his child vaccinated. And there are very typical problems. I'll tell you what kind of typical problems that he faces when he tries to approach this vertical, and how does he go about approaching the vertical. So the first thing that we need to do is that in every policy, I wouldn't sort of disturb the vertical system, which has sort of settled in after long years of experimentation. But rather than disturb the vertical system, I would say let's have a small sliver which deals with the migrants in that vertical. So whether it is non-communicable diseases like diabetes and other issues, heart, or whatever, that is something there. And a typical example where we have really succeeded and which we need to replicate here is when you look at the tribal subplans. So when we make the whole plan for the state, we always have a component which is called the tribal subplan. So if you're providing drinking water to the villages, you have a tribal subplan component which says that, go, this is what I'm going to spend and this is how I'm going to deal with drinking water for tribal areas. Not only that, you also have what is called a non-TSP component, tribal pockets in non-tribal areas. They have a special need. So you have a special budget, a special program for non-TSP areas. So it's not that we haven't done this before. We've dealt with verticals and we have slices in the vertical to deal with a population which may not walk with you at the same speed. So that's something I think in health we need to do something about the migrants at that point, and that's a policy intervention I thought we need to do. Second, we need to realize that every category of migrant is different with a different need. When a child is migrating, the first need is vaccination, the vaccination preventable disease. And why I say you need a sliver, a child born and living in that area already has a vaccination card. So next time when the A&M comes around to vaccinate, she knows which was the what is his turn to get the next vaccine. Is he looking at the next polio dose or a DPT dose or a whatever? They're aware of it. But here is a child whose parents are completely illiterate, and when she comes around vaccinating, they're just not able to say which vaccination he's already taken and which is the one which is due. Nobody knows that. And there is no continuity, there is no seamlessness in that. And that's a typical issue where we need to sort of get that seamlessness into this health issue. Secondly, women. When women are migrating, they have absolutely different issues that she may be expecting. She may have been looked at by a doctor at the village where she was and where she has migrated from. There were certain issues with the doctor dealt with there. There are certain sort of cautionary things that the doctor had in mind over there. But here she's standing in front of a completely new doctor who doesn't know any medical history. And everything starts from zero. And that's where the mistakes take place. These gaps can cause mistakes. And then there's the third category, the migrant who's actually going to work, whether it's the male or the female in the family who's actually going to work. They have a huge number of occupational health hazards, backaches, fatigue from the migration that they have done, the kind of area that they could be living in. Their problems are very different, and they could be just sort of covering that problem today, that health problem today, which might reveal in a very serious way tomorrow. So those are the other issues that, especially in this COVID that we have seen, because of this long COVID, there were issues that migrants have faced as occupational problems. Fatigue is one problem which we found that migrants have faced post-COVID. If they have suffered from COVID and when they came back to work, there was a lot of fatigue. So there's a different health issue altogether that he is dealing with over there. There's a fourth issue that we need to look at. A migrant is passing through various spaces where his vulnerabilities are different. So if he's traveling, and we saw during this migration phase, when the COVID migration took place, there were people who traveled by buses, trains, there were even people who cycled down, there were people who walked it down. So when you're traversing this space, there is a different kind of a vulnerability there. So whether you're a child or a woman or a man, you have a different vulnerability when you're transiting this space. Are we looking at health during the transit phase? No. At best, we can say, oh, I will look at health when he arrives. So I'll have a health camp to check him up. But did we care for his health while he was transiting? That's another very big issue, because the transiting could take 2, 3, 4, 5 days. And in that period, there could be some very severe permanent damage, which your health cam at the point where he arrives may not really be able to take care of. So these transit health issues are another very important thing. Lastly, to conclude, my feeling is that one, of course, you need policy interventions to look at the various verticals and how you get into the verticals. But I think one thing that could solve the issue in a big way would be if, now that you have Aadhaar available and you have most of the services linked to Aadhaar, can we not have a seamless connectivity where his health status, his vaccination status, and everything else is seamlessly available to him right from the point of departure to his transiting to the point where he arrives at? Yes, I do understand links are an issue. Computers will be an issue. But let us understand most of the migration is taking place into larger cities where this may not take place. At least, I wouldn't say to start with, let's look at 100% of the population. But even if you have covered 80% of the migrant population, I think we've made a very good beginning. And then we carry it from there. And I quote a typical example of portability in ration cards, the fair price system. Today, the ration cards in Maharashtra, and that has now happened over 24 states, are portable. So if I migrated into Gujarat or maybe Madhya Pradesh, my ration card is valid in a fair price shop there, provided it's linked to Aadhaar. So from at the point of sale, all I need to do is put my thumb there and draw my rations. And that's something that we are now trying in Maharashtra for tribals who migrate from villages to urban centers to work in brick kilns. So they come to work in brick kilns or factories and they carry their children with them. We have a program to give take-home rations or hot cooked meals to these children in the village they were staying. But once they migrated, we found that the same meal was not available to the children. Therefore, we created a system of cards where he could then report to the local Anganwadi there and draw his take-home rations or draw the hot cooked meal there, even though he was not a resident over at that place. So the nutritional status of the child did not suffer. So my feeling is that somewhere if we can get cards which help them transit seamlessly, you will then convert the right of a migrant to secure health from being a privilege to a right. It has to move from being a privilege, oh, well, if you walked in, you would get it, but if you don't walk in, you won't get it, to his feeling that, yes, it's my right. Here is a card that I hold, which recognizes me. And if I walk into this center, I shall get my take-home ration, my hot cooked meal, and my medical care. And my medical history would be known to the person who looks at it. So a seamless connectivity somewhere, I think, would help us sort a lot of problems and the missing link that is there. I'll stop here. Thank you so much.
Thanks a lot, sir. Thanks a lot. You've highlighted, I mean, I was just taking down some notes and you've highlighted some very important points. One is the absence of compassion, which is often, and last year in particular, we saw many images that really upset all of us because they lack compassion in terms of what the government or what the system was, how it was treating migrants. And a very closely linked issue was the lack of information that you mentioned. Often migrants didn't have the information. Actually, they were sort of caught by surprise last year. This year, perhaps not so much, but and actually that lack of information actually is not just limited to last year. It's just been it's been a lack of information, and the misinformation is actually another pandemic that we are sort of dealing with here. Also, the fact that from a policy perspective, as you mentioned, that policies they run on certain medical verticals of malaria and AIDS, and nobody is looking at migrants as a group, as a cohort. When the odd thing also, as you pointed out, is that within migrants also there are separate concerns that women and children and actual migrant workers might be facing. And actually, most of the women who are traveling might be working themselves as migrants, and and those concerns further. And also the vulnerability while you're transiting. So, I mean, we saw people coming from far off places like Bihar or Jharkhand to Karnataka or Maharashtra. And so what happens to them over this whole journey? And last year it was a torture to see what was happening to them. And then in terms of solutions, you've talked about the technical, the connectivity part, which possibly can be the next big game changer. Now, we have with us a fantastic panel because, as I mentioned, that this problem requires not just a rural and urban kind of a approach, because this is a shifting population. So let me first go to the two people who understand it from a very different perspective, which is from the community health perspective. We have Dr. Vandana Prasad and Dr. Pavitra Mohan. I'll come to Dr. Vandana Prasad first. Dr. Prasad is somebody who's associated with the Jan Swasth Abhiyan. She's a pediatrician herself, as is Dr. Pavitra Mohan, and Dr. Prasad has worked with the Right to Food campaign, and she's been very central to issues looking at malnutrition and also for tribal communities in states like Odisha. So I would first like to ask of Dr. Prasad, this was one exposition of where the problems lie. But of course, you look at it from a different perspective. Your experience is different. Please tell us, where do you think, what is it that migrants really suffer from? What is the main hurdle or main hurdles, as it were?
Thanks so much, Udit, and thank you so much to Ajoy ji for a very comprehensive kind of exposition, especially from the point of view of the system, and lovely to see that there's so much commonality between how we perceive things at the community level and how the system, at least in some states, at senior levels, is also looking at things. Just to add just a little bit about the experience, because I think it's important. I worked as a pediatrician and a doctor with the children of construction workers for about 16 years in Delhi. And I have been working in tribal areas for the last 10 years quite intensely, mostly with women and children on malnutrition. So I have had the privilege of looking at people in their source geographies as well as their destination geographies. And I think that it's very lucky to have seen that, that continuum of how it is back home and then how it is in the cities. And there are peculiar problems at both ends. So, and these are the problems, long-standing problems, which really much of which we could have sorted out with a certain degree of efficiency and ease much before this, that have been hugely exacerbated during the pandemic. And this is something we say about the pandemic on the whole with respect to the health system, that these are all long-standing issues that are now in our faces and creating disaster and suffering of untold magnitude. So it's the same with the migrant workers, and I completely agree that these are the people who have been the most vulnerable in our country. So the main issues that have beset this problem is one that your really fabulous clip also talked about. It mentioned the word invisibility. So their high degree of invisibility, to which I will add that when, not so much in their source villages where they kind of participate in the, extreme poverty and marginalization of that village community, because we know that migration is mostly still from push factors, in our country. Yes, the middle class migrates out of pull factors, but mostly poor people migrate not so much out of choice, but out of a dispossession and extreme poverty and just simply not being able to make ends meet. It's not that they really necessarily choose to migrate. So, so extreme poverty and deprivation and dispossession in their source villages. But when they come to destination sites, which are very often small towns, say Leke, metropolitan cities, there is not only an invisibility, there is also sequestration in pseudo-private spaces. This is very important to understand. For example, in the brick kiln, I investigated a brick kiln some years ago in Gujarat, where for 8 months, people would come there from elsewhere. And then for 4 months, they would go back for the agricultural season, which is commonplace for construction workers and everybody. So they had a dual identity as agricultural workers and the brick kiln workers. This happened year after year, and the brick kiln was 25 years old. There was a zero outreach from the government system in terms of ASHA and A&Ms to these brick kilns because they were considered private properties. And yet we have laws that are supposed to regulate. So, it's not, they are, that's why it's pseudo-private. Every resident and citizen of this country has entitlements that, and accountability that we demand from the government for basic rights. And all private situations, people are governed by certain laws and policies. But somehow in these areas, government is hesitant. Even when we deal with agencies such as the National Human Rights Commission, they feel that somehow the ministry also often says that we cannot go into private zones and private areas and regulate or monitor things or offer services even. So we argue that, and in fact, it did seem to work to some extent. But what I'm saying is that a lot of them are in, the largest sector continues to be construction sites. So construction sites where there is really very little ingress from the system onto these sites. Now, governing that is one of the oldest laws in the country, which is the Construction Workers Act, perhaps one of the only good laws that was created in the informal sector. And we have funds there. We have, I believe, I just read 30,000 crores in the Supreme Court, thing was talked about that these are the funds that are languishing there, but a complete lack of system as to translate that into rights, which would also manifest as health care on these sites and so on, and on other such sites. And we could possibly translate the sense behind the Construction Workers Act in terms of making services available, in terms of making additional funds available for the ingress into verticals, as was mentioned. And all this could easily have been made to happen had we had a strong political will to make it happen. So proof of residence continues to be a problem. We now have Aadhaar, but biometrics is a problem also. And I totally agree that we must have portability to align continuity of medical care. It's not an easy solution, but it's most certainly in digital India and so on. It's a doable solution. If we can have ATMs across the country, we can do this also for ration. We are trying it, and we could do it for other issues. So continuity of care has been a typical problem. For example, TB patient getting TB treatment either in the source village or the destination city, and then a complete disruption and interruption because the medical records people don't get anyway. We don't have a system of medical records in this country. We don't have any records that go from one place to another anyway. Even they're not even to be found in one single facility. So what would happen to this TB patient who requires treatment from 6 months to maybe sometimes 2 years? What happens when they travel and when they move? They have to struggle. They lose treatment for 2-3 months. They create all kinds of public health problems, from disruption of treatment, resistance and so on. What happens to a pregnant woman? I think Ajoy ji mentioned. What happens to a child with severe malnutrition? In our experience, beginning to improve in the village circumstances because we are running some direct services there, but then travels and then deteriorates again. So continuity of care remains a big problem. I would say that in the pandemic, one thing that we need to highlight, stop me whenever I'm overreaching my time, but one thing that we need to highlight is a feminization of this vulnerability. For the migrants, we continue to refer to them as mostly males, and that's true. It's true that as single person migration is mostly male, but that's not the only migration we have. Women come as construction workers, they do a lot of labor, and they have had to tackle sometimes they've not been able to come out for migration in this pandemic because their work has increased, I don't know how many fold. They are working as teachers now, as nurses for the rest of their families, trying to maintain wage work somewhere or the other, trying to do the agricultural labor as others try to migrate, and so on. So the economic distress has a very strong kind of feminization to it, and that has also translated in health issues, because we know that malnutrition and anemia amongst women is very high in the country. If you were to disaggregate, we don't have data on migrants, as you've said. We just don't have this data. Why don't we have it? I don't know. But had we captured that data, we would have seen, I have one series. It's not, again, migrant specific, but tribal specific, of 11,000 women where, about, if I remember correctly, about 14% were, as high as 14% were in severe malnutrition situations. BMI is less than 18.5 and extremely severe, less than 16. This is almost a moribund kind of condition, and they still labor, they still work. We've seen people working in the fields whose hemoglobin was 4 because it's chronic anemia they somehow manage. What has happened during the pandemic, it just kind of defies all kind of, imagination. Now, in terms of solutions, I think that what has been mentioned is portability, to arrange somehow for continuity of care. The critical issue in all our health circumstances is continuity of care. What I also feel is very important in our experience is that we need a very highly skilled facilitatory workforce. You need much more human resource in any situation of vulnerability. And here in particular, because of the issues that Ajoy ji has raised, the differentials in language, in culture, not having social capital, different layers of social capital we engage with. We might have a doctor in the family, you take help. You have somebody who's slightly richer in the family, you take help. These are people who are completely dislocated from their social capital. So we have been working during the pandemic, particularly on platforms that have tried to do health discussions for money, for medical facilities, for access to healthcare and so on. And in this course of action, we've also engaged with people who are migrants stuck in the cities and not being able to access things. And we find that it takes a huge amount of labor and effort. So if you were to institutionalize this, apart from the simple mere portability, I think just to engage with digital, systems, just to engage with another class differential of people, very different from their own, different culture, you need a different workforce entirely. Community health workers who need a specific kind of orientation and training, compassion is the key. But I would say, just to end, I think just now, or second last point, that along with compassion, I think we also need to be aware that their rights and their rights holders, equal citizens, brothers and sisters. The last point I want to make is a stigma and discrimination, which hasn't come up yet in the conversation, that, when migrants went back home, they, in many places, they were welcomed and panchayats made a lot of effort to take them back. In many places, it was the opposite, and they were, we've seen and heard stories of migrants who had to stay under trees and eat and drink under trees for 3 days and be quarantined and so on, because we didn't have community-based facilities. So I think that arranging for community-based facilities for quarantine, isolation, so on, that particularly respect migrants who are coming back, is certainly going to be important from all our points of view. There's a lot to say on the socioeconomic front, but this is your third series, so I'm sure that you've already talked of very, very basic things that are the determinants of health, which is socioeconomic status, the high degree of economic inequity, just the fact that nobody gets minimum wages, and so on and so forth. So I'm just going to stop here for now.
Thank you. Thank you, Vandana. I think Udit has probably, there's some power cut or some loss of connectivity there, and I think he was anticipating it, and he said that if that happens, asking me to take over. So yeah, thanks for that, Vandana. And Pooja, would you like to take over, or and maybe in any case I was to go next? So.
Yeah, maybe you can go next.
Okay. Thank you. Thanks. So, I would probably just shift a bit to what happened during COVID-19 in the first phase and in the second wave, and what we are seeing on the ground, and how that affects the larger kind of issue of healthcare of the migrants. Last year, when in March the lockdown was announced, we saw all those pictures. And there were a large number of people who returned almost immediately before they were officially allowed to, right after the abrupt lockdown. We work in areas of South Rajasthan and in the corridor of Ahmedabad, Gujarat and South Rajasthan. And what we started seeing were a large number of people returning back on foot, on bicycles, on motorcycles. All of us saw those pictures, quite broken and distressed. And we were, kind of looking at what is happening to the COVID situation amongst the returnee migrants, and we were closely looking at it in a population of about 100,000. And we saw that in the first wave, when people immediately returned, the infection, the COVID infection was really very, very small. It was really not a wave. I mean, there were very few people infected, and that did not lead to a spread of the pandemic in the area, in high migrant communities in rural areas. However, after the first month or so, when they were officially allowed to come back, by that time the cities, they were holed up in the cities for a month or so. And during that time, they contracted COVID, and when they returned, there was a small surge which lasted for next 2 to 3 months. And that was the end of it. So what we were seeing was not so much affected by COVID, but there was quite a few issues which was related to the response to the COVID in that time in high migration communities. That was related to closure of all health services, absence of transportation, acute shortage of food. That led to an increase in diseases like tuberculosis, where people were not able to access healthcare. Government services were focused either on COVID or on nothing at all because they were closed. Childbirth significantly increased at home, leading to an increased risk of maternal deaths, etc. in those areas. There was a significant reduction in immunization coverage over the next 3-4 months, which would, and these were all kind of high migration communities where some of the simple protection that we are able to reach as a state are these services, right? I mean, which is safe childbirth or immunization, which we were not able to provide for several months during that period. And we saw what is often known as a syndemic, where COVID was there, but it was also associated with a sharp increase in both incidence and flaring up of tuberculosis. And of course, as usual, during these times in these high migration areas and high tribal populations, malaria epidemic also started rising with very limited access to care. Food shortage led to we kind of regularly do surveillance of children growth monitoring in several villages, where we saw 1.5 times increase in malnutrition levels among children in these communities. And then of course for next several months when COVID even in the cities kind of declined before the second wave, one of the things that was a remnant of the first wave was the way the migrants were treated while they returned. As Mr. Ajoy said, that in general they don't feel assimilated in the cities, but during this time they felt further alienated, and that had a huge impact before the second wave when immunization, just before the second wave when immunization was being promoted. That distrust and fear and alienation from the system led to a lot of distrust and failure to accept vaccines. And when the second wave hit, failure to actually access healthcare in these areas. About 40 to 50% migrants in the areas that we work in had returned from the cities, especially the closer cities like Ahmedabad, where they could actually come back during this period. Also putting at a huge risk because they came back in crowded buses and crowded vehicles because we do not have a transport system. As Mr. Ajoy very rightly said, the transiting poses a huge challenge both in terms of safety and in terms of contracting diseases like COVID on the way, right? I mean, if you're traveling and that's also, I'm raising this point because it's already started happening now. When people are returning back, they're returning back in the same overcrowded buses. And that was one of the contributing factors to flaring up of COVID in the second phase. I think at this point of time, this reclaiming of trust among the migrant populations in high migration communities at source is also extremely important as we kind of move ahead to control the epidemic and build trust with migrants who in general had poor access to health services and limited trust in public systems to begin with. So yeah, I would just stop here for the time being and would ask Udit to take over and if he any other kind of next set of questions.
I'm sorry for the power cut at my end, but I wanted to come to Ms. Mahadevan, as some of you might know that she's actually, you're the nodal head for trying to put together efforts from the private sector, from NGOs, from NRIs to somehow direct as much help to tackle the pandemic. And you're also heading a ministry which sort of gives you a good sense of what's happening in the interplay between urban and rural areas. You've looked at COVID management in the state. So, one thing I honestly want to know, and this I wanted to ask Professor Srinath Reddy also when I come to him, then one is the issue about data. So this issue about data where we do not know details about many of the things that both the doctors just pointed out, how can that be solved? That is one. And the second thing is, you've heard many of these things that they've said about happening in different industries, and what are the solutions now when you're looking at it directly right now? Are there any innovative solutions that you're looking at, or how are you seeing the question?
Thank you for having me. And it's been very interesting listening to Mr. Ajay Mehta and also to Dr. Vandana Prasad and Dr. Pavitra Mohan. I have no doubt that the rest of the panel will be equally interesting. As you said, Udit, I'm the nodal officer in Karnataka, looking after the coordinating with civil society organizations, with corporate sector, and also voluntary organizations on COVID response. I also happen to be posted as Principal Secretary Panchayat Raj. In both roles, very interested in how we can help people in difficulty. And we've also had a closer look at not only the health side of the COVID response, but also the difficulties that people have faced, both in the first wave and in the second wave. It's been very interesting listening, as I said, to Mr. Mehta, Dr. Prasad, and Dr. Mohan. Some of the words that I've picked up are about the invisibility of the migrants. What makes people invisible to policy is something that we should think about. Also about sequestration in pseudo-private places, which may not necessarily be out of bounds to regulation and should not be out of bounds, certainly to care. And how can we reach these places? Because reach is the most important thing. We often talk about, as I always say, in the rural services, we talk about reaching people at the last mile. But I've often started wondering and articulating also whether we should really flip that and talk about the first mile, because that's where we really need to start if we're adopting a truly decentralized approach. Reach every person, not to ensure that no one is left behind, but to actually take forward people. And language really adds to, language in these cases matters because it adds to a certain integrity of our processes that we're designing. We also, I think both Dr. Prasad and Dr. Mohan have spoken about documentation. So, and Mr. Mehta suggested that we could have a digital solution. And as we would all agree, there is an uneven quality to digital access across the country. And therefore, we need to keep that in mind. Certainly, that should be the long-term goal, keeping in mind the necessity to protect privacy too of all individuals, but also to use the potential gains of a digital solution. But in the interim, until we achieve a satisfactory and robust digital solution, we should really look at the problem that we have today in the here and now is the problem of lack of documentation. Everybody looks after their Aadhaar card or the document that they have. Everybody is perfectly capable of looking after. Everybody knows that we need to look after it. Why should we not give poor people access to their own health documentation, which they can carry with them? Why should a TB patient coming from Jharkhand to Karnataka not have details of the medication that they've been given, the number of months that they've had their treatment, what is the treatment plan, so that they can contact the next primary health center for continuity of care? I have two major points that I want to make. One is that we've been talking about community-based healthcare services and the need for community-based. What is community? We have 2.5 lakh. It's not a particular hobby horse of mine. It's something that I've started understanding in more and more greater detail as I've started working in Panchayat Raj. We have 2.5 lakh gram panchayats, which are elected local bodies in rural India. Whether people come from a source state to a destination state, if they're working in a brick kiln, if they're working as brick workers or as construction workers, more often than not, they are working in an area where there's an elected local body, except for very few places where elections may not have happened for one reason or the other. There's an elected local body, either rural or urban local body. Now, all of these health workers, frontline health workers, ASHA workers, Anganwadi workers, all the services that we need to give, even if you just list off the top of my head, I was making a list of the services. The first thing that a migrant coming from another state or even from within the state, from one district to another district, a plantation worker going from, say, Yadgir to Kodagu to work in the coffee plantation would still require rations, so PDS, would still require, if the child requires to be in an Anganwadi or if the mother is pregnant, would require take-home rations from the Anganwadi, would If there's a child who's a school-going age, would require school enrollment, would require midday meal, would require healthcare at the primary health center or sub-center, would require, if there's a problem, if there's a criminal, if there's a police problem, would require to know the police station, would require access to know where the nearest bank ATM is. It's possible to provide. In fact, earlier this afternoon, we were talking in my team about creating, we've created a platform for a pandemic response, connecting requests for help with offers of support. We were talking just about this, about the possibility of creating on this a way for a mapping to be done of all the government facilities, the service delivery units, the nearest Anganwadi, the nearest primary health center, the sub-center, the post office, the bank branch, and also the one-stop centers, the police station, if somebody's in distress, the Indira canteen, if they need, a relief food and so on. It's possible to connect, and also to connect with nearby civil society groups who may be able to help with advocacy. So this is possible and it should be doable. Also, we can do this in languages. Already our teams, volunteers are working on producing material in languages. Until we reach a robust, as I said, a robust digital solution, we can do this in multiple languages. It's possible with tech to do this in Hindi, in Maithili, in all the different languages, Odia. Information in bullet points. We can talk very, confidently about portability, but portability, the 3 pages of a complicated government order need to be explained in bullet points, in simple language, maybe in a 45-second audio visual for people who are actually, for whom it makes the difference between whether they're going to eat that week or not, right? So that's something that can be done. And it's time for us to start thinking of actually ways to actually just go ahead and do it. And also, maybe we could have a call center. There's no reason why we can't have migrant resource centers, which are already available in certain areas with different civil society organizations. In Karnataka, for example, there's Sampark, there's LaborNet, there are different groups that work with migrants. Why we can't think of a statewide call center, a one number, and even, I would even go so far as to say a welcome pack for migrants who come to our state, whether it's from the construction employers, whether it's from the brick factory, whether it's from the Gram Panchayat. Let's start thinking of doing this as a welcome pack. This is your pack. This is the nearest set of service providers, your Anganwadi, your bank branch, your school, your primary health center, your so-and-so, and put this material, make it available in the Gram Panchayat, make it available in posters in different languages. Also give them, many of them have smartphones now, make it available in languages on the smartphone through an application which is possible. We are part of the way working on doing this. So I'll have more information to share, and love to show versions of this certainly to Mr. Mehta and Dr. Mohan, Dr. Prasad, others over here to get your ideas. I think this is something that we should really just go ahead and start doing. Gram Panchayats, in Karnataka, for example, Gram Panchayats are mandated to prevent and stop exploitation through bonded labor practices. Most brick workers, for example, families come as units, husband and wife come as units, but the woman is never documented. It's not just the medical document. If you look at the NMR, she probably doesn't have her name on the muster roll, but it's entirely possible for local governments to get information, to connect them to the Anganwadi, to connect them to the health center, to connect them to the school, and make sure in a constructive way that certain entitlements and a certain feeling of welcome and a certain feeling of security starts setting in. We'll have to do this in many waves, but I seriously think it's possible, and I seriously think it's time for us to do this. Thank you so much.
Thanks a lot, ma'am. Thanks a lot. I would like to now go to Professor Srinath Reddy. He's possibly the most well-known face on public health in India. And he's somebody who's worked on this issue for the longest time. And he's been part of the Universal Health Coverage Plan also when we were thinking about it. He chaired the. Sir, I would like to hear from you, what is your sense, where have we gone in terms of not taking care? I mean, one of the panelists made that point that I think Dr. Prasad made the point that none of this is a surprise. Actually, we knew that when something goes wrong, it will show up like this. So where have we gone wrong? What's your sense there?
Thank you very much. Let me first start off by saying that we have been discussing mostly rural to urban migration, which possibly is the most visible element, and that became particularly poignantly visible during the COVID pandemic. But apart from the rural to urban migration, we have rural to rural migration, urban to urban migration, and even urban to rural migration, particularly as has been pointed out during the agricultural season. So it is the big challenge of ensuring not only on-location services, but also the portability of services when they move from location to location. That's absolutely important. Let me also raise the issue of data that you have asked about and what Vandanaji has pointed out. In September 2020, the central government announced that by June 2021, a comprehensive database of migrants would be prepared. This was because the courts took notice of it, because the National Human Rights Commission took notice of it. But as of now, the preparation has not started. This has to have been delivered this month. Now, that is partly because I believe the attention shifted away, even from the media. Now, after the initial concern about what the plight of the migrants was, and those moving images which disturbed so many out of their comfort zones in the cities, when the wave appeared to subside, what happened in terms of ensuring that we had a continued follow-up of the kind of remedial measures that had to be taken to see that such distress would not be repeated again. Such gross violation of rights would not be again something that we would have to inflict upon the migrants. So that, I believe, is a collective failure of societal conscience. And secondly, let me also say that it's not really useful for us to say that we should only examine what happened to them during the COVID period. That was an acute exacerbation of a long-standing neglect. Of course, there are a number of sections of our population who are actually deprived of essential health services in terms of accessibility, in terms of appropriate care, in terms of affordability. All of those are major challenges, and that is why we call for universal health coverage, not merely to protect human productivity, which seems to be the preoccupation of those who look at migrants as a human resource, but also looking at it as an essential human right. Both go hand in hand together. It's not merely the forces of economic productivity, which are very important, of course, which need to be looked at, but the fundamental aspect of ensuring that it's seen as a respectful recognition of a human right. Now, if we actually look at what's happening, even when there is no pandemic, where is the protection that is happening to them in multiple locations? Whether it is a sugarcane farm where they suffer a lot of thresher injuries, or construction sites where they suffer other injuries, or stone quarries where they get silicosis, are more prone to tuberculosis. There are multiple types of occupational injuries, but even the routine health problems that affect everybody are not properly attended to because they are a migrant population without roots or recognition in the area where they actually go to work. Now, it has been said that we should be able to provide them adequate care, even at the location of where they are going to be working, with possibly a welcome package. wonderful indeed. I would entirely welcome that. But let us look at it. Where is the primary healthcare center they can go to? Are they accredited there? In Delhi, at least the Mohalla clinics are taking them in for immediate healthcare problems. Delhi, they're also talking about opening women's Mohalla clinics to look at gynecological problems of women. But when they go to a hospital, will they be entitled for the Pradhan Mantri Jan Arogya Yojana? Would they have the adequate documentation for that and for them and their children? We do not know. Those who may have the documentation will be privileged, those who do not will suffer. Now, the 15th Finance Commission has very rightly said that all funds for primary healthcare must go to local bodies, to the panchayats and to the urban local bodies. I entirely support that. But what would happen if the administration of the local body, particularly the elected political leadership of the local body, says that only people who are actually our voters are entitled to this? So in this urban ward, if I am not a voter there, and if I'm not entitled to that privilege, and if I can't go back to my village where the panchayat may give me my citizenship recognition, what's my fate? And therefore, the portability element is non-negotiable. If health is seen as a human right, and we ensure that everybody with proper documentation or without proper documentation is entitled to that right, preferably with documentation, of course, but that should not become a barrier. Take a case in point. What about vaccination? Now, if with all this problem that has happened in recent days between the center and the states, suppose the center finally has not accepted and said, we will also take care of everybody's vaccination for adult vaccination from 18 onwards. I do not know what will happen to the children later on, but we will take the responsibility for vaccination. That's what they've said now. But if that had not happened, if a state chief minister would have said that I will spend my state money only on my citizens, then what happens to the poor migrant? Does the migrant and the family get vaccinated or not? What about the states which are not implementing the Pradhan Mantri Jan Arogya Yojana, which brings in an element of portability? If they only have state-level health insurance schemes, which apply only to their residents, their bona fide residents, then what happens to the migrant? So these are the challenges of policy that we must address. I entirely agree with the initial introductory comment that health has to be elevated as a human right, not as a charity to be conferred on the migrant. And if that is so, then we have to make sure that there are really no barriers. While we use our technology to get them registered, get their children registered, we use everything possible to make sure that they're entitled. But let us take a case of a migrant. Let me read out from a report commissioned by the National Human Rights Commission. Now, according to the survey commissioned by them, and this has been released only a few weeks ago, according to the field survey, 68% of the women covered by our survey do not have access to toilets as they live in slums or squatter settlements. This is Delhi. In Mumbai, about 62% of migrant workers live in slums. The study claims that 43 interstate migrant workers die every month in Delhi, 35 in Gujarat, 41 in Haryana, 38 in Maharashtra, due to accidents at construction sites, suicides, and stomach-related diseases and heart ailments. This is not related to COVID migration. This is their daily plight. This is their monthly misery. So unless you actually build a caring and compassionate healthcare system, which is actually looking at reaching out health services to every person in this country and make sure that the migrants do not suffer, in particular because of added misery, added difficulties in access, then that's where the problem is going to be. Now, what happens to a migrant in transit? The Human Rights Commission has asked that. Now, if a rural migrant is coming to the city for work or going back to the village, what happens if there is a problem in transit? What are the facilities there? And while working on location in the city, What is the healthcare facility in terms of primary healthcare personnel visiting them at their place of stay? Are they going in for immunization? Are they going to check what's happening? Is the ASHA going there? Is the Anganwadi worker going there? Are they entitled to go to every Anganwadi center? What is happening in terms of their healthcare at the construction site if there is an injury? Or in stone quarries, if they're prone to tuberculosis and silicosis? What is the public health measure that's being taken in order to prevent it? It's not merely curative medicine. What is the public health access reach out to them? What is happening to them in terms of primary care facilities if they have to go and seek primary care? What is happening to the hospitals when they have to go there? Again, Vandana ji has mentioned the linguistic and cultural barriers that exist, the discrimination, sometimes that makes them a rejected group. So all of these are challenges that need to be addressed. COVID has only made them much more vivid in our visual field, but these problems have existed. And indeed, if you take the Sustainable Development Goals, virtually most of the goals will have to be looked at from the prism of how the migrants have been affected, whether it is poverty, which is goal number 1, whether it is hunger, goal number 2, whether it is health, goal number 3, whether it's education, goal number 4, gender, you can name it. Every single sustainable development goal, or most of them anyway, are related to health, and most of them have been violated in one way or other when it comes to the way society has been treating migrants. And therefore, I would say that if you really want a summative indicator of your success in sustainable development goals, then think of the rural girl child, her life expectancy and her state of health, and that of the migrant girl child in an urban area, her life expectancy and her state of health as the indicators of India's development, not the GDP growth year by year. So I will end on that point, and I would say that is probably what Gandhiji's talisman would say, that think of the poorest woman and the poorest man. This is where the migrant must come straight into our visual field, not as a temporary fleeting fancy, or not as a momentary stirring of our conscience, but as a commitment to create a universal healthcare system which is going to stand by their rights every hour, every day.
So this is a very important point that you've raised. I mean, we, as Ms. Mahadevan pointed out, there are great ideas at the state level, and also what Mr. Mehta talked about, that often there's lack of information about what the migrants might, the facilities they might get from the government hospitals. But I would like to take it back to Mr. Mehta and Ms. Mahadevan. Is there a need for a sort of a national charter on this? I mean, which takes it beyond just individual states deciding on their own and saying, well, we are a better state. And I say this knowing the complexity that different states now are actually competing very strongly, because there are states also which are not wanting migration on the face of it, like Haryana deciding it, or even a Jharkhand coming up with a law saying, we'll reserve jobs and stuff. So one by one, maybe if Mr. Mehta could give a quick response to that, this whole, should the response to the migrant issue be a national solution and not left just to state level initiatives?
I think migration will have to be dealt at both the levels, because it's not just a national issue or just a state level. You have, for example, in Maharashtra, we have a lot of state level migration. In fact, that's why Maharashtra was the first state to start what is called the employment guarantee scheme. Because the whole concept then was, is the link okay?
Yes, we can hear you.
And just when we got.
Have we lost him?
Is the link now okay? Udit? Yeah, Udit, is it okay?
It's better now.
Now. What I was saying was just quickly, we need to respond at both levels, state and the center. If you see, Maharashtra was the first state right in the 70s to start an employment guarantee scheme, because then the emphasis was to prevent migration. because we are a rainfall short area, and therefore people would migrate into large urban centers like Pune, Mumbai, Nagpur. So we started an employment guarantee scheme to see that migration doesn't stops there. Similarly, national migration is also a big issue today. The kind of migration that takes place into Mumbai from various states is a big issue. So therefore, I think we need to deal with it at both levels, both at the state level and the center level. But fundamentally, I think what needs to happen, the string that needs to run through is that migration has happened and will happen. Let's not shy away from it. Let's not make it a political issue. Let's try, and I wouldn't say just find a solution, an administrative or a bureaucratic solution. Let's try and find a solution with compassion and also realize that migrants are contributing to your economy. Whether you look at it, whichever way you look at it, definitely they are contributing to the economy. And basically, it's a human right issue. So if you look at it that way, I think we would be able to find a solution.
Ms. Madhavan, what do you have to say on that issue about how to deal with the nature of migrants being a sort of a national problem and then having state level solutions? So on that issue?
Yes, I agree entirely with Mr. Mehta. I think it needs to be resolved at national level as well as state level. I think COVID has not only made the invisible visible, acutely visible, in many dimensions of the problem and the vulnerability of migrants, especially of women migrants, of children who migrate, travel along with their families. We all remember the picture of the little child asleep on a suitcase while the mother is dragging her along. But it has also made certainly many states realize and communities realize that migration within the state as well as from outside the state is a part of fueling the economy. It's how, it's how the economy runs. They contribute, they add to the gross production. The work that's happening is of value. And that recognition is also slowly but steadily coming. So I am optimistic, and I think highlighting this and discussions such as this about what are the actual constructive, functional things that need to be done one by one, coming up with a charter of action points at the state level as well as the central level would be very useful and would help to resolve many of the problems, because solutions are there, both technological as well as policy solutions. The will has started to come, and I think we need to work on making this happen.
Thank you. Very quickly, if I could have responses from Dr. Vandana Prasad and Dr. Mohan on this issue about what Srinath ji mentioned. Vandana ji?
Yes, thanks. I think we're, heading into now complex territories, which really will have to be tackled if we are going to find solutions. And Srinath ji has mentioned at least one of them, which is resources. There is going to be competitiveness between states if there is a general resource crunch. And I think this brings into play center-state relations, how funds are shared in this country, and so on, which are very critical to any generosity of spirit. Eventually you have to think there are people voting for me and they don't have it, and then there are people who are, in inverted commas, coming from the outside. So who do I choose? When you have to choose and make these terrible choices, which really perhaps we could have mitigated some of these choices. So I think that the issue of resources is quite central. It's one of the elephants in mentions also, which is, just to take it further, which is a basic economic paradigm. Here we're mentioning that they contribute to the economy, but we're still saying this sort of apologetically. But I think they are the very underpinnings of Indian economy, is it not? And yet at the same time, the paradigm of economic development and growth is, is it ready for equality in any terms, or lessening of economic inequity in any terms? We abhor trade unions. We think trade unions is a bad word because you don't feel that collective should be arguing for better working conditions and better wages and so on. And we say that this will, change the spectrum of our productivity as a country and our desirability for cheap production in this country. And other countries have exploited that again and again. So these are the truths. These are elephants in the room without which we cannot really, we can mitigate, we can do some compassionate work. But can we really do solid work in terms of bringing up this certain population, which are, as I say again, our brothers and sisters? And the third is even in terms of our response to the pandemic. When we announced and continue to announce in some degree lockdowns, I'm not completely against lockdowns. I just want to make it very clear. But we are making some choices which create tensions and discomfort. Either way, it's uncomfortable for us to realize these truths that in the COVID pandemic, deaths didn't happen only from COVID-19. They happened for non-COVID reasons, pregnant women not being able to make it to a facility, people with heart attacks not being able to make it to facilities, and they have happened for hunger and starvation mentioned by all, and these are public health issues. Now, had we considered impact on livelihoods, impact on hunger and starvation, food security, impact on non-COVID health conditions that required us to remain open to some extent, would we have changed our stance? I think we have already, because much of this has, come on between the first wave and the second wave. It has moderated our responses. All I'm trying to say is that our responses are highly conditioned by not the most poor of the poor, and not keeping that in mind. And if we were to do that, it has some very genuine tensions. It'll cost us as a society, and we need to prepare ourselves for that cost. In real terms, it is really how we are we really prepared for what the domestic worker, what we would have to pay as taxpayers, and so on and so forth. And we see these debates every day. So I'm just going to stop there.
Before I go to question and answers, just a last word from Dr. Mohan on this issue.
I think just kind of taking this discussion ahead on what really affects the health of the migrants and what needs to be done on a priority basis. I think if I have to choose a few, as Dr. Srinath Reddy talked about the several determinants that affect health of the migrants, I would point out a few key ones. I think the living conditions are one of the very central determinant of health of the migrant. The condition in which they live, you cannot talk of health if 50 people are living in a room without water, without toilet, without ventilation. Especially in times of COVID, we have understood the value of ventilation. But before that, a lot of them were suffering from tuberculosis and no kitchen. You can't cook in a place which is closed. And so I think living is such a central determinant of health of the migrants that we have to, and I'm glad that Mr. Ajoy is here, and maybe subsequently we can think of what are the policy ways to promote housing, a safe and secure and a healthy housing. Most developed countries in the world have invested in safe housing for the migrants and for the population in the cities. And that has been very central how public health engineering and public health developed. And this is something where we have absolutely failed our migrants and failed our city dwellers in general. The second, I would say, is working conditions. And, without talking of occupational health, some of the examples that Dr. Reddy talked of, silicosis, which we see so much in South Rajasthan, where people are dying at the age of 30s and 40s, because they have been involved in stone carving or in mining. And without talking of occupational health and ensuring safe conditions, which are all part of our policy framework. There is an occupational safety framework. Of course, it has been recoded now in a separate code, but it still provides for safe working conditions. People dying in Gurgaon, 25 people losing their fingers every day. So how do you ensure occupational safety? In absence of that, it is difficult to talk of healthcare of the migrant, because most of these people who work in the most hazardous situations are migrants from different cities and not the local dwellers often. The third is what we are talking of about access to healthcare. So I would say that it is not portability alone, because point is, as a citizen of the country, health is the right. There is the survival is a fundamental, is a constitutional right of everyone, with or without portability. You don't need to carry anything. Ideally, you should not need to carry anything if you. So denial is, I think, that, and that's where migrants are especially more affected, because just to prove that you have a document, so the policy should be towards universalizing, not for saying, for example, even now I'm hearing about COVID-19 in our own areas. The question is, how do we prevent wastage? I said, look, this is not the time that we have even come to ensuring how do you, and that leads to that mindset leads to denial of services. And therefore, I think universal access to healthcare for the migrants, wherever they are, would be important, irrespective of whether the documentation is there. And more importantly, I think the point that Vanna made earlier about the private spaces or the pseudo-private spaces, that is where the health and the invisibility, the problem, even if you are portable, you got all the entitlement, but you can't access because you're living in a factory or in a construction site where there is no health service that reaches you. So I think just ensuring mapping these populations and ensuring access by the local health system, considering them as the local population, I mean, for example, in Ahmedabad, we worked at several construction sites where just the fact that we were able to link these populations to the local health system, they were now connected with a basic thing as immunization. While earlier and in most other places, immunization does not reach these places because they're not listed, they're invisible, they're in pseudo-private spaces. So I think mapping them out, ensuring access as a to services would be very important, because they can't, you know, they work 12 hours. I mean, many of them work for 12 hours a day. Where do they go for accessing services if they are not closer by, if they are not at the time that they can get free in the evenings, or in the language that the providers understand them? So I think these making services, health services, migrant friendly, which means that they're closer to where people live, they are inexpensive, and their language and the responsiveness of the system is there. So I think making, and Mohalla Clinic, the example that that Dr. Reddy gives, comes closer to that. It still needs many more, you know, so which is at least closer to where people live, and that's why it was kind of a hit with the migrant. So I would stop there and give this framework of living conditions, working conditions, and access to healthcare as three important, you know, pillars of when we look at so to kind of, you know, grapple with this complex situation. Just in the end, I would say, and since Professor Reddy is here as well, that the health policy of India, national health policy, does not have a word on migrants. It does not have a word on occupational health, and none of the state policies have a word on occupation. I mean, probably there's a mention of occupational health in one word or somewhere, but there is no provision for migrant health or occupational health in our policy framework at all, and that's a huge anomaly, I would think. So yeah, I just end there.
Thanks. We have Professor Reddy has a hard deadline at 7:30. So I just wanted to take one more minute of Professor Reddy's time and ask him if there is one thing or two things that he would like to outline that we must do as a country, and not just state level or center level. What are the one or two things that we must do going forward? You're muted, perhaps, sir.
While the program of universal health coverage must develop over time, let us not wait for that to happen. Let us make sure that there is a fairly well-constructed plan which looks at what the health needs are, both in terms of public health and health care of the migrants in different settings, and ensure that there are adequate resources allocated for that, both monetary and in terms of the health workforce, and bring facilities as close to their residential sites and to their places of work as possible. Even if they are mobile clinics, let us make sure that happens. So you have to make sure that health services reach them rather than for them having to flounder around and be discriminated against.
Right. Now let's go on to some questions. We have Professor Omidyar Rajan, who's the chairman of the International Institute of Migration and Development. He wants to make a comment, I think. Can we patch him through?
Thank you for the participants. I think I heard very well from the four speakers. I just want to make basically 3 points. One is, I think, which I wrote earlier, I think we have to prioritize the vaccination for migrants. And people are telling, why should we prioritize? I think we should not think migrants as somebody outsider. They are Indians. We should first tell them migrants are Indian. We have only Indian passport. We don't have Kerala passport, Maharashtra passport, Tamil Nadu passport. If you have passport for Indian, same thing, why can't we think of a universal immunization for migrants as a priority? Because last year we told them they were the carrier. If they are the carrier, I think we have to give them first priority to see that they don't carry the what is called the COVID-19. The second point, I think I heard from all of you, but I think something we are still missing is the mental health of the migrant status. Mental health is something very huge. And I don't know, we are not talking about returned migrant suicides because people are getting into absolute poverty. We have statistics on farmer suicide. I don't know how many returned migrants went back to the villages and they found nothing and they are getting suicide. I think the suicide of returned migrants should be something we should look at it very, very seriously, like we look at the farmer suicide. The third point, I think what also we had during the COVID second wave, even the middle class failed to get what is called the ventilator oxygen. Can you imagine the situation of the poor migrants? I think they cannot get anything. And added to that, we are trying to import ventilator and oxygen. But what about the human resources? Who will handle this ventilator? I think this is something we should look at it as a migration policy of this country. Because, for example, in India, we have 1 doctor per 1,000 population. But if you look at some countries like UK, you have 5. And they have 5 because our Indians have migrated. And you take the nurses, we have 1.7 nurses per 1,000 population. In Australia, they have 14. And you go to Australia, most of them are Indian nurses. So we are allowing them to go. There is no problem. People have to go. But at least we should have a return migration policy. You know, we should relook at the policy of the migration. People are going away. That is good. You can import ventilators. Can you import the human resources to handle the ventilator, handle the oxygen? Because many times the people who are handling oxygen is not handled well, patient might die. And finally, I think the time for us to look at the migration contribution for the economy, I think we should document that. We are always, looking at them negatively. I think without them, there is no city in the country. We are talking about smart cities. I was telling them smart city means what? Without migrants? Smart city without migrants, can you imagine smart cities in this country? We have a smart city mission. I think this is something we should relook at into the policy. We have to mainstream migrant issue into policy development. For that, the Finance Commission, when they distribute resources, they should talk about migrants. I told the chairman of the Finance Commission, when you distribute money, just don't distribute based on population. You should distribute which are the states where they are getting more migrants, give them more, so that they will not talk about money crunches. I think we should think some type of novel ideas to attend to the migrants. I will stop here. Thank you very much.
Thank you, sir. Very valid points he raised, and especially the mental health aspect. This is something that is a bit of a silent crisis, which perhaps we'll wake up to at a later stage. But yeah, let's go on to the next question. I would request, this is Mr. Shambhu Ghatak from Common Cause. I would request you to please ask the question, and please also tell me who are you asking this question to? Yes,
Hello.
you are.
Okay. Good evening, all of you. And I appreciate that you have accepted my question. I would like to ask this question to Dr. Pavitra Mohan. My question goes like this. The out-of-pocket expenditure of an average Indian on healthcare is quite high, whereas public expenditure on health as a proportion of GDP in comparison to other countries is low. Although there are health insurance schemes for the poor that are being implemented by the center as well as the state governments, like Ayushman Bharat, most of the migrant workers have not been able to access them because of portability issues, lack of residential proofs, lack of awareness about such schemes, etc. Many of the empaneled hospitals under the Ayushman Bharat scheme did not function optimally last year during the lockdown. The health infrastructure, especially in rural areas, primary health centers, community health centers, and district hospitals, is in poor shape and also inadequate to serve the poor masses.
Could you just quickly complete the question?
Yeah. So in this context, what should be done to enhance the purchasing power of the migrants so that they can access private services, at least though it is insufficient? Should there be an urban employment program in addition to MG Narega? Should there be cash transfers? Thank you.
Let him answer. Let him answer now. Yeah.
So I don't know. I'm not really competent to answer the latter part of your question about the urban rural employment, etc. I can come back to that. But I think in your question about the people slipping into poverty because of high out-of-pocket expenditure and migrants unable to access benefits under PMJY or Ayushman Bharat is absolutely valid. And I think there are two parts to it. One is the whole plan is so it is designed in a manner that it is very difficult for people to go and enter a fancy hospital and know that that it is for them. There are apparently and the understanding of which hospitals are accredited, how far it is, what will be free, what will not be. It does not encourage people to really go and seek services under the Ayushman Bharat scheme. There is also, I mean, people are we did a small exercise in Ahmedabad where we tried to with about 100 migrants, we try to call that number to confirm whether they are empaneled or not, because it is said that you don't need a card, you just need a number, and none of them were able to really access the to find out from that number whether they are empaneled or not. So you can't enter a hospital without even knowing whether you are really empaneled. So I think there needs to be so much more effort. It is potentially useful because unlike many other schemes, it is valid across the states. That was something we had been talking for a long time. That most of them were earlier state-funded insurance, which will not be valid across the state. But this is something which is valid across the state, but there is not enough facilitation to make it work for the people who would not be able to to access healthcare in a hospital in a city, and therefore much more effort needs to be done in that regard. Whether that would require, the evidence so far has been that it has not substantially reduced any out-of-pocket expenditures. In most of the state-funded health insurance schemes have not played that role, and ultimately the reduction in out-of-pocket expenditure would happen with good quality primary healthcare being closer to where people live, and in case of migrants, both at the source and at the destination, because remember, their families are also going through a health crisis back home. So unless there is good quality primary healthcare that is available both closer to where they live in rural areas, which often are remote and tribal areas, and in urban areas, again, as I said, that they are living in spaces from where and they operate in time zones and in duration that make the health services not migrant friendly. So to my mind, the solution does not lie in the fancy insurance scheme, but much more in the nearby, closer home kind of health facilities, which will also become your passport to the larger health insurance. If you require hospitalization and if you're able to access a neighborhood service, one of the jobs of primary healthcare service is also to help you link with the secondary and tertiary care services, which is what the Ayushman Bharat scheme offers. So so I think having good quality primary care is the key, and then only can you really help people link and make full use of the secondary and tertiary services which are available in these insurance schemes.
Thank you. Thank you. Let's go on to the next question. I think this is Mr. Divyang Shah. Somebody's mic is on. Could you please mute it? We have next question by Divyang Shah. Can you please tell us who are you asking this question to?
Good evening, sir. This is Dr. Divyang Shah. I am head of the medical services and L&T group, and also the Central Council member of Indian Association of Occupational Health, which is the largest occupational health association for the doctors who are working in the industry. I have a question to all the panelists. I don't address any particular one. What should be a strategy for the vaccination of the migrant workers? Because as we heard that migrant population are moving around and it is very difficult to track. Yes, in the large organizations, we can vaccinate them, especially in terms of the COVID, but they go out, that is fine. But the incoming population, whether they are vaccinated or not, it is very difficult to track. So what should be the strategy by the organizations to track of the migrant workers or laborers COVID vaccination? Number one. Number two, in current development of the government announcement of vaccinating all the people, we know that the government is having the limited resources at the primary health centers and even urban health centers in terms of the manpower. So can it be possible to do the vaccination camps at the labor colonies or at the workplaces directly by government, if not by government, because of the resource crunches, they supply the vaccine, and the organizations or industries can provide the local logistic and administration support in terms of infrastructure and registrations and other admin. So that these are two my points.
Who do you want this answered from?
We have the enlightened panelist, bureaucrats and administration. So anybody who can answer this. It's just
Mahadevan, can you hear me?
Sure.
This issue about vaccination,
Vaccination of migrants. Certainly they should be vaccinated. Everybody should be vaccinated, everybody above the age of 18, since the vaccine is available. As and when the vaccines become available in different states and different health centers, they should be vaccinated just like everybody else. And workplace vaccination is also happening. So there's no reason why workplace vaccination should not cover them. Yeah, Udit? Can't hear you. I think you're muted.
You're on mute.
Is there a concern here about vaccine hesitancy? And misinformation regarding the disease itself?
Yes, there is hesitation about the vaccine, and I think one of the panelists, at least a couple, I think, have spoken about the fact that migrant workers have had a difficult time last year in their experience. You know, the panic, the fear, the inability, the thought about being unable to go home, and so on. A general fear about healthcare itself, about the ability to access healthcare, about whether they're getting correct information. They're also cut off from their languages. And so I think some work needs to be done. Certainly in several states, I know groups like ours are already working on, lots of civil society groups are working on translating material about vaccination, reassuring. I think people have a right to be reassured about rather than employers making it a mandatory thing and getting vaccinated for that. People also should be treated as individuals with a right to have their fears assuaged and to have some reassuring information in their languages and in material that works for them, whether it's audiovisual, whether it's text, whether it's people talking to people, whether it's role models, and such material can easily be prepared and should be done. And I think several rounds of counseling them in this reassuring way will be certainly very helpful. And that's something we can do.
Right. Next question. Could you please be brief and exactly tell us who you are addressing the question to? Do we have the next question? I think it's by Mr. Vinay Patel.
Yeah. So, hello everyone. I am Vinay Patel from Urban Management Center, Ahmedabad, and we are a not-profit organization, and we are working with Migrant since last 6-7 months, and we initiated the program of Embrace, that is called Empowering Migrants for Building Resilience through Comprehensive Entitlements, which is the corridor of Gujarat to Odisha and Surat to specifically for the Ganjam. And I would like to share some learning lessons and some policy level and health improvising thoughts into the forum.
I'm sorry, just a second, Mr. Patel, is there a question that you have? Is there a question?
Yeah, so I have a question. The common documents.
Please quickly ask that. We are short of time.
Okay, so sure. So there are various social entitlement schemes available at the national as well as the state level, but the common documents is not allowable to get entitlements, money things. Second, the job employment letter is not providing by some of the industries to unorganized workers. Third is, we say one nation, one ration card is initiated, but there is a very 2-digit numbers is providing the ration in other states. Fourth is the primary health care facilities. We call the Ayushman Bharat and Jan Arogya scheme, but that is for secondary treatment. Migrant workers need a primary health care facilities like a Mohalla clinic in Delhi example, or in a Deen Dayal mobile clinic in Gujarat examples. It should
What's the question, sir? What's the question? What's the question?
It should be, the question is to establish a migrant cell at all state levels, and that is coordinated with each other. It should be the requirement, I think. Yeah, that's
should we establish migrant cells at state level? Yeah, I suppose. I mean, that is something that I think Ms. Mahadevan also mentioned. But it's very clear that it's more than just about setting up cells, and as Dr. Mohan said, that we need to go beyond just talking about portability and talk about universalization of some of these issues. So let's move on to the next question. I think it's by Lata Sardesai. Can we patch her through?
Hello.
Yes, ma'am. Please go ahead.
Yeah. I actually wanted to ask regarding the skilled labor. We are having shortage of skilled labor now in the city, be it any area, be it a hotel or be it any industry. The cities have lost. So I just wanted to ask, are these skilled laborers coming back to cities, and what is the plan of government to employ them? Second, about the ration, when we call that health is priority, the ration or nutrition becomes a part of it. You cannot, these are 2 points. You cannot just go on saying that we have to give them vaccination and all. Unless you give proper nutritious food, you cannot talk of all these things. So primary is the nutritional benefits to be given through ration.
Let me just take that to Ms. Mahadevan. Ms. Mahadevan. Yeah. Ma'am, would you like to take up that question about what measures can be taken to bring back skilled laborers? I mean, what is the scene? What is the impact on skilled labor? And
I am not really aware of any, impediment as such compared to what we're seeing in Karnataka, since relief measures, other measures have been announced in phases. We are not really seeing a move out, a drain of skilled labor. So I'm not sure what the situation is in other states on that. Yeah.
Okay. I think we're coming to the last question now. Can we patch her through, Ms. Ranjana Das?
Yeah. So this is specific to Dr. Pavitra Mohan. So as we understand that the existing healthcare system is not adequately covering the needs of the migrants. So a couple of suggestions from you, sir. How do we overhaul the health system now, given that the pandemic is, ravaging us? And is there a possibility of looking into the national health policy in the light of the migration policy, or vice versa? So, yeah.
That's a small question, but one can respond to it. Probably the whole webinar was around it. So yeah, but I think maybe very rapidly, I think if there are some small if there's some quick measures or some low-hanging fruit, so to say, immediately, if that's what you think, I mean, there are no low-hanging fruit, but I think if we can use this opportunity to strengthen a few things. One is, as I said, that no denial of services. If we can implement this, saying that whether it's for vaccination or for access to healthcare for migrants in the cities. Second is which we have done extremely well in the polio elimination earlier, where we had mapped, and we still have those. We have mapped every single person in the city, whether they're migrants or working in the brick kilns or construction sites, and ensuring that we provide access to services to begin with, some basic services like immunization, antenatal care, care for women, at the sites or closer by, with respect. So I think the third is, of course, linking to really helping, facilitating without any difficulty access to hospital care. And finally, I would say that, just making our services a bit more migrant friendly, which are more open in the evenings, they are located well. And as Dr. Reddy said, that if in the short run that's not possible, at least reaching out with mobile services, etc. Those would be some of the quick wins, I would say. But I think I would still go back to the fact that some of the fundamental issues we really need to deal with, and housing and transportation, to my mind, are really, really important, critical at this point of time. If we also have to look at strictly from a selfish and an immediate COVID pandemic point of view, because ventilation is almost equal to vaccination in its potential impact on reducing the epidemic, as well as in several other ways that you can impact the health of the migrant population. So. Yeah, but it is a long question, and I know that in such a short time it may not be possible to. But I think also again, as everybody has said, that accepting them as a victim and not as a perpetrator of the disease would be a good starting point.
Thank you, Dr. Mohan. Thanks a lot to all the participants, all the panelists here. I'll throw it back to Pooja. Because we have Shilpa also with her concluding remarks. Pooja, all yours.
Thank you, Udit, and thanks everyone on the panel for sharing your insights and valuable thoughts with us. Yes, now it is, I would like to invite Shilpa Kumar, who is partner, Omidyar Network India, to please come and make the concluding remarks.
Thank you, Pooja. Thank you, Udit. And really thank you to all the panelists for a very rich discussion, very insightful discussion. I think COVID-1 really focused on migration, COVID-2 focused on healthcare. And I think the axis both put together really focuses attention on healthcare for migrant workers. So I'm really, finding this discussion extremely useful. I thought some things that I took away, one is really the double alienation. The fact that there is a lack of assimilation, there is sequestration, but at the same time, there is also lack of access. I thought those were important points. And then the fact that alienation happens at various different points, whether it's across life cycle, whether it's across gender, spatial alienation, in transit, also alienation of access to whether it's physical or mental health. And really, the other thing that came out, Udit, you made this point right at the beginning, was the fact that healthcare is a government monopoly, especially, at I would say, the demographic we're trying to reach. And therefore, how do you overcome the fear psychosis even before you actually enable physical access? And some wonderful points were made about building trust, whether it's to do with trust in the system, access to information about the nearest healthcare centers, availability of this information in local languages, and who's the human capital that can make this connect and build the trust. And I think very important role for maybe NGOs and civil society organizations over there. I thought the last thing that I took away really was the role of technology. And can something like technology, Aadhaar enablement, actually allow for portability of healthcare in a seamless fashion. Of course, one does need to worry about possible exclusions, possible privacy issues, but I thought that was, the other thing I took away. Maybe in conclusion, I can just share that at Omidyar, one of the reasons we had picked up our Resolve initiative was really to, in a sense, focus effort on this very important issue of migration. And like Dr. Mohan, you said, we thought to focus it on data, dignity of livelihoods, and dignity in living. Very last sentence to this long evening is the fact that COVID is just a trigger, maybe, but having raised such important issues, how do we find the will across state, civil society, businesses to really make significant change happen? So thank you again for such an insightful discussion.
Thank you, ma'am. Thanks a lot. We'd like to now also, of course, thank our presenting partner, Omidyar Network India, for helping us put this series together. Thank you everyone who joined us today. We will continue this series focusing on specific aspects of migration, like education, housing, labor laws, in a bid to get a deeper understanding of the challenges that lie ahead, and in the hope of finding some direction. We will be in touch as soon as we announce the next event. Thank you.